Hello, and welcome to another Rush Generations Health Education Lecture. We are so delighted to be your source of information, resources, and health promotion programs that help maximize your well-being and good health as you age. Today is Wednesday, October 15th. I'm Grisel Rodriguez Morales, Rush Generations Program Director, and so glad to be your moderator for today's lecture, Breast and Lung Cancer. Before I present to you the wonderful speakers joining us today, I'd like to first thank our producer, Hannah Weitzman. Hannah is also going to manage the chat and other key aspects throughout the lecture so that we can all have a great conversation about breast cancer and lung cancer, including the risk factors, warning signs, and screening recommendations. As always, we're live streaming this lecture via our YouTube channel using the video platform Zoom, which allowed us also to host a good number of people who join us via phone. Thank you so much for joining us. For those of you on YouTube, we ask that you please use the chat function to ask questions or to add to the discussion throughout the lecture. We will make sure that your comments and questions make it to the presenters. And for the callers, please know that you will also have an opportunity at the end of the presentation to unmute your audio so that you can ask your questions. We'd like to remind everyone that all the information offered here is for educational and general informational purposes, and to always seek additional professional advice for those situations that are very specific to you and your needs. Okay, let me introduce you to our speakers. Today, we are very glad to have Donnaline Schaefer, who began her career in the U.S. Navy overseas, then had 20 years in information technology before getting into healthcare, first leading breast health education for Chicago Southside communities with Amani Trinity United Health, and later serving as community outreach navigator for the Metropolitan Chicago Breast Cancer Task Force, which is now Equal Hope, in which Donnaline continues to promote breast health awareness and early detection through community outreach and partnerships. Then we'll hear from Irene Hapoya, who recently celebrated her 35th anniversary as a cancer center advanced practice provider. She specializes in thoracic oncology, providing care to patients undergoing treatments as well as survivors. Thank you, both of you, for being here. I guess that I'll hand it to you, Donnaline.
Good morning. This is our afternoon session on breast health. As everybody know, this is Breast Health Awareness Month. Just an overall view of the workshop. We'll learn a little bit about Equal Hope. We'll talk about the risk factors, detection and treatment, and what you can do to help your family survive breast cancer. As we move forward, what is Equal Hope? This is just a picture of my team. My team, they're a great team. Part of the ladies that you see here are the navigation team that I'll be talking about very shortly. Equal Hope was founded in 2007 after there was a call to action because Black and brown women on the south and west sides of Chicago were dying at an alarming rate due to breast cancer. The reason that women were dying, there were three areas: unequal access to services, the quality of the mammograms, and also the quality of the treatment. In 2008, Equal Hope did get brick and mortar on the Rush campus, and we've been there ever since. And the parts of Equal Hope, we have equal access is what I'm doing right now. Equal Voice is where you come in. You can be a part of our advocacy team when we go down to Springfield and we talk to our legislators about bills and services that we need in our communities to have access to quality services, to have quality services. And Equal Care is our research team that does such a great job in researching the healthcare policies around the city of Chicago and the suburbs. So let's get into it. So what is breast cancer? Cancer is what happens when let me just put it this way to make it real quick and easy. It's when the cancerous cells in our body start to outgrow the normal cells, whatever part of the body. And right now we're talking about breast cancer. So when you have unhealthy cells growing uncontrollably and very rapidly, it can turn into cancer. So here you see an anatomy of the breast. I just want to point out, where the fat, the skin, the nipples. Now the ducts, where you see the ducts are, is usually where cancer starts to grow. Same things in alluvia, that's usually where cancer starts to grow. So what we see here now, breast cancer is a malignant cell or cancerous tumor. And so right here where you see here is a normal breast duct. Here's where you have DCNS, where you have cancer within the cell. And then the third picture you see is when the cancer starts to spill outside of the cell and it starts to become invasive, which means that it's flowing to different parts of the breast as well as outside of the breast. So who gets breast cancer? Statistically, from 2017 to 2021, 52,000 women, almost 53,000 women were diagnosed with invasive breast cancer. 12,000 of those women were diagnosed with in situ breast cancer. In 2021, deaths among women because of breast cancer invasion, 88 was all races, Hispanic. 116 of 116 of those women were non-Hispanic, and 112, 1,600, I'm sorry, 1,600 were all races, but for the Black women, it's 340, and for non-Hispanic white women, it was 1,216. Breast cancer is the second leading cause of cancer in women, in deaths in women. And here we have a map. The map kind of shows you the mortality rate per 100,000 females in each area of the city. This map here shows us 77 communities of the city of Chicago, starting up here on the north side, going all the way down to the south side. If you see the areas that are deeper purple, that means that we have more mortality rate. The mortality rate is higher in these areas. And as you can see, these areas are the south and the west sides of the city. So what are some of the symptoms of breast cancer? Some of the symptoms of breast cancer, number one, I'll say, all the time when you talk about symptoms of breast cancer, we always talk about lumps. Lumps is the most common thing that you talk about when it comes to breast cancer. However, I would caution you to know that only 80% of the time, if you have a lump, would it be cancerous. That means 80% of the time, if you have a lump, it's going to be non-cancer. It's going to be benign. So there must be some other things that we should be looking for when we're talking about cancer. So dimpling of the nipple, that means you have dimples in your nipple. Changes in your skin, rashes that won't go away. Your skin might have a rash starting like little red dots and turn it to start maybe feeling like an orange peel. Discharge from the nipple, anything red, green, brown, or black, you really need to go to the doctor to make sure. It could be infection, it could be blood. If your nipples start to turn inward, again, you would need to go up to the doctor to make sure that everything is okay. The size or shapes of your nipples change. Again, is a reason that you should go to the doctor. Or swelling or under your armpits, you might have a lump. Lastly, pain that won't go away. Now, this would be different from the pain that you experience during your menses, because sometimes when we're pregnant, or we're on our menstrual cycle, that we might have pain. But if you have pain in one spot in your breast that just won't go away, then you need to see the doctor. Now, I'm going to go back to the lump again because I want to be very clear. Although I said there's only a 20% chance that the lump in your breast is cancerous, you still need to go to the doctor to get that lump checked out, because the only way you're going to know if it's cancerous or non-cancerous by going to the doctor. So what are some of the risk factors of getting breast cancer? Being a woman, age, family history, and genetics. Being overweight. Now, the ones that I mentioned before are non-modifiable. That means things that you really can't change. But being overweight, not exercising, drinking one or more alcohol beverages per day, or taking hormone replacement therapy. And so, ladies, that would be birth control, basically, when we talk about hormone replacement therapy. But there are other hormone replacement therapies, but you should definitely talk to your doctor about those. Breastfeeding can definitely reduce your risk in getting breast cancer. And so real quick, I want to talk about breast density. Breast density is very important. If you have dense breast tissue, then you would need to do maybe an ultrasound or MRI versus getting a mammogram. So you see here in figure A, you can see right through the breast. There is a sign of cancer right there. There's hardly no density in this breast at all. But on B, you see a little scattered density, just a little bit, but you can still see the cancer, or the suspected cancer, I should say. When you get over here to C, you can barely see it. And definitely D, you can't see it at all. Now, how do you know if you have dense breast tissue? That can be told to you after your mammogram. The doctor should let you know what your density grade is so that you would know the right way to go when it's time to get your screening. Men do get breast cancer, but it's only less than 1% of the time. And they basically have the same symptoms as women. And some of the risk factors, again, are the biggest one is family history, obesity, age, heavy drinking, exposure to radiation. That's maybe like getting an extra amount of x-rays. I mean, a diagnosis for men would be clinical breast exam, which means that's a physical examination of the breast, imaging testing, and then followed by a biopsy. There is a 1 in 8 chance that a woman will develop breast cancer. That means out of 8 women on this call, one of us can be diagnosed with breast cancer. Well, let me change that. That number is national. 1 in 8 women will be diagnosed with breast cancer. Breast cancer is highly treatable. If your breast cancer is found before it spreads, you have a 100% chance of being alive 5 years after. I know tons of breast cancer survivors. And I tell you again, even though there's only a 20% chance that a lump is cancerous, a lump should never, ever be ignored. Whether you had it checked out and they said it was okay, and if you may see another one, you need to go and get that one checked out as well. Never, ever ignore a lump because you never know. And again, breast cancer is highly treatable. And when we say highly treatable, that means that the treatment that you get for breast cancer, if it's caught very early, could be very minimal and could not maybe sometimes include chemo. Maybe sometimes it won't include radiation, depending on when it's caught. But we want to be very cautious about lumps and finding lumps and getting them treated right away. So how do we diagnose breast cancer? We usually start with a screening mammogram, then we go to an MRI. If a suspicious lump is found, there's an ultrasound. You have the clinical breast exam. Sometimes you might find a lump on your own. And of course, you go through a biopsy if a lump is suspicious. And so the way we say it at Equal Hope, there's 3 methods of early detection. The first method is being self-breast aware. That's knowing your breast, what's normal for you. And again, knowing these, I'm going to go back. to knowing some of these symptoms that we talked about, knowing what's normal for you. So if something changes, you'll know that and you'll be able to see it right away. The second method of early detection is a clinical breast exam. That's a physical examination of your breast by the doctor or nurse practitioner. The mammogram or an MRI, depending on your breast tissue density. The mammogram will find a lump as small as a pea. That's why we recommend getting mammograms every year. The average lump found for the mammogram, you can see the figure here. The average one found by the mammogram is probably the size of maybe a grape. And then the average mammogram found by a woman doing self-breast examinations will probably be the size of a cherry. And then lumps can also grow to be the size of strawberries. So you really want to check your breasts on a regular basis, say every 30 days, and on a daily basis, you just want to do an overall body audit, looking at your breast, checking to make sure that everything is still the same. Mammogram results that come back normal, you just go back once a year. If you have a suspicious, so let's just go through this real quick. If you have a suspicious lump, you may have to go back. So let's just start here. A screening mammogram is a mammogram that's going to look at the whole breast. When you have to go back for follow-up and diagnostic mammogram, it's going to look at just one area of the breast that they see suspicion. If that area is suspicious enough, then they'll recommend a biopsy. If breast cancer is found, women have the options of having a lumpectomy, which means they just remove the lump, and then you discuss with your team whether it's going to be radiation combined with chemo, or or by itself, or radiation by itself. Some women opt for full mastectomies. Some just have the one breast removed. Breast cancer spread, but breast cancer is spread. We do, again, mastectomies, hormone therapy treatment, radiation, chemotherapy, and target therapy. Again, when you get to this point of cancer treatment, you work with your whole team. That would be the oncologist surgeon, your primary care. Everybody works as a team to help stop the cancer from spreading. So taking action, here are key things that I want you guys to take away from today. Knowing what your risk factors are and knowing your own body. Getting your mammogram every year starting at the age of 40. Maintaining good health and establishing good care with a primary care provider. And mostly, don't be afraid to follow up. One of the things that I didn't talk about at length was, and I think I still have a little bit of time, one of the things I want to talk about is how we treat our bodies. Ladies, we know that we have to treat our bodies with care in order for our bodies to care for us. So we want to make sure that we're trying to change some of the risk factors that we can. For modifiable risk factors that we can change, we can exercise more. And I'm not talking about going to a gym, getting a membership, working out. I'm talking about doing something that you really love to do. Let's say bike riding. Cleaning house, that's an exercise, help burn calories. Some people like to run. Some people like to swim. Some people like to dance. Line dancing is a big one in the community to help maintain your health. We need to change from eating outside a lot to eating in-house with more fruits and vegetables in our diets. Changing from drinking juice that has a lot of high fructose corn syrup in it to natural juices, to juicing ourselves, just being a little bit better with our bodies. And if we're going to drink alcohol, let's make sure that we're drinking water before and after drinking alcohol to kind of rinse out our bodies so that we can be good to our bodies, so that our bodies can be good to us. Make sure that you're getting your mammogram starting at the age of 40 every year. again, the earlier breast cancer is detected, the better it can be treated. When breast cancer is diagnosed early, the overall survivorship is 5 years. It's 99% 5 years. And tell other people to get their mammograms. For people that you know, tell them to get their mammograms. And again, when breast cancer is diagnosed early, the overall 5-year survivorship is 99%. Please keep that in mind and don't be afraid to get your mammogram. I went to a funeral yesterday and it made me so sad. My coworker, her mother died of breast cancer, and she told me yesterday that her mother was diagnosed with breast cancer right after birthing her 10-month-old brother. So the woman had her son and was diagnosed with breast cancer. She died 10 months later, and my coworker told me that her mother didn't get her mammogram because she thought mammograms caused cancer. It made me very sad because women can't survive cancer if it's caught in time. Schedule your mammogram, ladies. So I tell you, these are some of the things that Equal Hope can help you do. The navigators that I showed you, my navigation team at the beginning of this slide, they'll help you schedule your mammogram screening appointments with or without insurance. They'll send reminders for you. They'll assist you in getting timely results. They'll make sure if you have an abnormal that they get that scheduled follow-up in a timely manner. They'll assist you in getting immediate treatment. I have a coworker, name or letter, who will help you and go with you throughout your treatment. They also provide free transportation. They'll assist with diagnostic follow-ups and breast cancer treatment. Now, also, in addition to that, the Equal Hope Navigation team can also help you get cervical cancer screening and medical home placement if you are a person without health insurance. And how do you get in touch with Equal Hope? It's very easy. You can give us a call at 312-942-3368, or you can go to our website at equalhope.org, or you can come to our office and see us at 300 South Ashland. I am going to just say that at the end of this year, we will be moving to Sankofa Wellness Village over on Madison and Kildare. So please check out our website, equalhope.org. And you can even sign up for services. You don't even really have to talk to me or one of the other community health teams members to get signed up. You can sign up online at Equal Hope. Ladies, that is the end of my presentation. Thank you so much. I really appreciate you having me and Equal Hope to share our information about breast cancer awareness.
Thank you so much, Donnelly, not only for the information about breast cancer, but also the services that Equal Hopes provide. And yeah, we'll be neighbors. We're going to be bringing some of the Rush Generations programs to Sankofa as well. So
That's
great
awesome.
collaboration. Yes.
That
I
is
guess
awesome.
that we are going to open it now for Irene to join us. Let's see. Oh, great. Thank you. I cannot hear you, Irene.
Okay, here I am.
Now, perfect.
All right. Hi, my name's Irene Hapoya, and I'm one of the thoracic oncology nurse practitioners at the Rush Cancer Center. And thank you, Donna Lynn. That's a hard act to follow. So I just wanted to talk a little bit today about lung cancer and just where we are right now in 2025. And just about what gains we've made in lung cancer diagnosis and treatment, and what our hope for the future. So next. Okay, keep going. All right. What I'm going to talk about today is lung cancer statistics, a little bit about lung cancer screening, which has really made a big difference, a big impact on our ability to diagnose lung cancer earlier. This is comparable to a woman getting a mammogram. I want to touch on what our current treatments are and our hope for the future. Next. Keep going. Okay. So in 2025, right now, there will be over 220,000 new lung cancer diagnoses. This number is actually decreased from what it was 10 or 20 years ago. We will see about 110,000 cases in men and about 115,000 in women. So as you can see, that number is higher in women, and it's like, what? Well, why is that the case? And really what that reflects is that it used to be higher in men, but you know, the primary risk factor for lung cancer is smoking. And years ago, and I'm talking about the 1900s, early 1900s, when smoking, you know, even prior to that became just fashionable. And going through the 1920s, 30s, 40s, 50s, that really men were the people that were smoking more often, and women started later. So what happened is that we've actually had a peak in the diagnosis of lung cancer cases in men, and we've reached that peak in women. But what we're seeing is that we're still seeing more diagnosis in women and I expect that to drop as those numbers, you know, start coming down because of the decreased incidence of smoking. We just have such a delay in even when smoking occurred earlier in people's history, and then there's a delay in the time of diagnosis. So you may have stopped smoking maybe 20, 30, 40 years ago, but could still have a lung cancer diagnosed. So actually, the majority of lung cancer is diagnosed in people who are either non-smokers or current smokers. It's actually unusual to see someone who is a current smoker. Most people quit a number of years ago. We do expect about over 120,000 deaths in this year. Again, these numbers continue to decline, and we've made great strides, I would say, in the last 20 years. When I first started at Rush 35 years ago, really, you know, our 5-year survival was very low. We've seen that increase to currently now the survival rate for lung cancer for 5 years for any stage is 28%, which actually that over the last 10 years has decreased over 25%, which is very significant. And what is that from? That's really from the decline in smoking. We've really seen a decline of about 5% per year in the incidence of smoking. And that's been very significant. With people turning away from smoking, we've seen the laws with regard to smoking in public places. We think that's made a significant difference. The decrease in secondhand smoke, again, so the other risk factor for lung cancer can be radon exposure, and now that's become more knowledgeable. People have radon tests that they can do to test and see if radon's present in their home. So a lot of things that have really contributed to this decrease in the 5-year or improvement in the 5-year survival rate. So, you know, I've mentioned that lung cancer can occur in non-smokers also. And that's very important to note, because what we say is if you have lungs, you can develop lung cancer. So it's really not confined only to people who smoke or have smoked. And I think, you know, that's part of the stigma that's still attached to lung cancer, is people feel that it is a smoker's disease, and it really isn't any longer. I see people who are diagnosed with lung cancer, unfortunately, in their 20s and 30s and 40s, and they never smoked at all. So why do these people develop lung cancer? They probably develop it due primarily to genetic factors and environmental factors. So the genetic factor, we're still, you know, trying to learn about. There is not a lung cancer gene that has been developed, that has been detected, as opposed to breast cancer. We know that there's certain genes that if they get turned on, you know, cause the development of breast cancer. We don't have that in lung cancer, but we do know that certain families have traits. We have followed these families to see, what about them, what's the genetic differences that have occurred so that we see lung cancer developing more often in that family, but we're still investigating that. The other thing is environmental factors. Any type of environmental exposure with regard to mostly particulate matter in the air. They think that diesel fuel is something that especially can lead to the development of lung cancer. So of course, laws that help to make sure that our air is clean, supporting the Clean Air Act, and decreasing our exposure to those types of particulate matter can be very important. Lung cancer does remain the leading cause of death in cancer right now, and actually more deaths than breast cancer, colon cancer, and prostate cancer combined. So the important thing is that we need more research and more research dollars devoted to lung cancer to, again, keep these numbers coming down as they have been. Next. Okay, so I just want to talk about what are symptoms of lung cancer and what you can do to prevent lung cancer or, again, detect it early. As in breast cancer, early detection is really important, and the treatments and the effectiveness of those treatments and the survival rate significantly increases. So what are signs and symptoms of lung cancer in anybody, whether you have a smoking history or not? Any type of persistent cough or shortness of breath really needs to be investigated. So what do I mean by persistent? If it really continues more than several months from when you feel like you initially had your viral event or your upper respiratory infection, if it keeps on longer than you think it should be, and even 3 months later you're still coughing, that should be investigated. You need to go to your primary care doctor and hopefully get a physical exam, maybe get an x-ray, and just to have that investigated further. Certainly if you're coughing up blood, that's a very significant sign. It could be just because of the infection irritated your airways and you have some inflammation, and that's causing, some irritation and causes the tissue to bleed a little bit. That's not uncommon. But if it persists, if it goes on for several weeks, that's something that needs to be investigated. If you have any chest pain or tightness, now this is kind of more of a vague type of symptom, but if it's transient, if it only happened, for a little bit, again, it was maybe associated with having a cold, but then gets better. But again, if it continues, that needs to be investigated. If you have hoarseness, that continues also. So if you have a cold and it gets better and you've had these symptoms, but then they improve, that's fine. But if it keeps on, we should take a look at it. And again, this is kind of more of a non-specific thing, but if you have persistent weakness or fatigue, you should be seeing your primary care doctor on a regular basis. And if these are symptoms that continue, these should be looked at. So next, I wanted to talk about what the importance of lung cancer screening. So just like Donna Lynn talked about mammograms for diagnosing breast cancer, we now have lung cancer screening, which is a CT scan, which we can use to diagnose lung cancer. So we do have very specific criteria as to the types of people that should be screened. But we do know that we've been using lung cancer screening now for over 10 years, that if you screen people who are at high risk and they get screened annually, just like a mammogram, you can reduce the lung cancer rate by about 20%, which is very significant, because you can find these at an early stage when the lung cancer is going to be more likely to be curable. Next. So this is a CT scan. So it is a specialized test. It's going to show more than an x-ray. So people used to get annual x-rays as part of their annual exam. X-ray is good, but an X-ray isn't going to catch something that's very small. So just like Donna Lynn talked about, when a lump can be detected by a woman, that's going to be bigger than they can find it when they see it on a mammogram. So the same thing, an X-ray isn't going to catch something that's very small. So you really need a CT scan. The CT scans that are used are given with low dose radiation, and the slices on the CT are done so they can really find something that's only a few millimeters big. So then we talked about that using CT scan to detect early lung cancers can decrease the mortality rate by about 20%. So you can see, in the early 2000s, the deaths from lung cancer were actually close to 160,000 people a year. And when lung cancer screening began just before 2015, you can see how quickly the lung cancer deaths dropped down to what our current situation in 2025 is around 127,000 deaths per year. So it's a significant improvement. Next. So I wanted to talk about what is involved in lung cancer screening. So this is something that you should be talking with your primary care doctor. We do have a big lung cancer screening program at Rush so that you can contact and be involved in that directly. But if you can discuss this with your primary care doctor and then they make a referral or they order the CT scan, that's ideal. It is part of looking at an annual exam. So once you start lung cancer screening, you would be doing it yearly. It is for people who are considered high risk and for developing non-small cell, but also small cell lung cancer. Those are two different kinds of lung cancer. We do the screening. It's not recommended for people who have had a history of lung cancer in the past because those people would be followed differently. You don't want to get it if you've been doing any other type of CT scan. And there is certain criteria that I'm going to go over right now. Next screen. So the guidelines for lung cancer screening, we currently, and these have been revised in the last 5 years or so to be a little bit more expanded. So currently they're for people who are in the age range of 50 to 80. And they either are current smokers or they quit in the last 20 years. And we also look at something that's called pack years. So you need to have smoked for a certain amount to be eligible for this type of screening. So the eligibility is for someone who's smoked at least one pack a day for at least 20 years or half a pack for 40 years. So these are the eligibility criteria to undergo lung cancer screening. So again, a smoking history is something that is considered part of the criteria. Again, in non-smokers, we're trying to put the word out that lung cancer can occur in those people because sometimes someone who is younger but has symptoms isn't acted on as quickly as it should be because no one thinks that there's a possibility lung cancer could develop in this type of person. But again, if you have symptoms and they persist for several months, that's something that should be investigated by going to your primary care doctor or even going to a pulmonologist or someone that can do a physical exam, listen to your lungs, and look at, getting a low-dose screening CT to see what's going on. Next. Okay. So if, unfortunately, you do have a lung cancer diagnosed, there are certain tests that we do to develop what stage that is, and that would involve, again, starting with that CT scan and then going on to probably a PET scan, which can show areas of activity in different parts of the body, checking an MRI of the brain. There are certain staging criteria that we do, staging exams. But I did want to talk about the importance of the advances that we've done in lung cancer treatment. So just like Donna Lynn referred to different treatments that we use for breast cancer, we use some of those same treatments for lung cancer. We use chemotherapy, we use surgery, targeted therapy, radiation, and also immunotherapy. So immunotherapy has really been the game changer in lung cancer treatment over the last, I'd say, 15 years or so. There's a lot of different immunotherapies that we use, and we also use them in combination with chemotherapy, with targeted therapy. So really, it's important to look at lung cancer as being treated not in just one way, but using all of these different modalities can come into play depending on the extent of the lung cancer and what kind. So one thing I wanted to say, again, with regard to diagnosis, you do, if a lung cancer is found, you're going to go ahead and have that biopsy done. We do have a lot of advances now in interventional pulmonology where they can do a bronchoscopy and go down and get a sample of a very small nodule in the lung, which is less invasive than doing a surgical procedure. The importance, I say here, of molecular testing. So anybody who has a lung cancer biopsy done, they're going to make the diagnosis of lung cancer. It's so important to have molecular testing done where they look at the cancer and they see if there's any mutations in the cancer. And some of those mutations are actually what's driving the cancer to grow. So we call these oncogenes, where they get turned on and they cause this accelerated cancer cell growth. We do have treatments that can turn that switch off and cause the cancer cell to die. So it's so important for every lung cancer patient to have molecular testing done because we can find out, and this is what's called precision medicine, precision treatment, what is unique to you and to your lung cancer that can help determine what your treatment should be. So this used to be more important for people with more advanced disease, but now we've really moved it into earlier stages because now we're doing neoadjuvant treatment where we're giving people, they're candidates for surgery, but we're going to give them chemotherapy and immunotherapy before to shrink that cancer and actually kill it by the time they go to surgery, because we've done that in patients and they go to surgery to have the cancer taken out and the cancer is completely dead, which is not something we saw before at all. So doing this testing, figuring out if there's a mutation in the cancer, giving these treatments ahead of doing a surgery are all the really significant advances that we've done to really impact, the survival rate in lung cancer. So molecular testing is critical. Also making sure that you have a team, again, your oncologist, and then the rest of the team involving the surgeon, the radiation doctor, all working together to treat that cancer. So we have had a lot of advances in this area. We've been able to find cancers earlier. We've made headway in terms of the smoking rates, which have really impacted the amount of lung cancer that develops. And then we've made a lot of headway in terms of lung cancer treatment. The other thing that we've really seen happen in the last decade is the advancement of people surviving lung cancer longer. Lung cancer is turning into a chronic disease for these people. I now have lung cancer patients that I've known for 10 years, 20 years, who they had one treatment and then we had advances in clinical trials and we found another treatment. So then they went on to that treatment. So we've been able to just move along as the science is progressing, and that patient has benefited from it, and they've been able to go from treatment to treatment. And that's helped to extend their life and actually extend and improve their quality of life. So I'm fortunate that our lung cancer survivorship community is increasing. We now see strides in lung cancer advocacy. So we have patients, just like the breast cancer community has, to advocate for lung cancer research. So we have people who are just getting out there and spreading the word about the importance of lung cancer treatment and investing in lung cancer research. So I want to say there's a lot of hope for the future. It's a very exciting time. I've seen just so many great strides happen in the last 30 years. It's really just overwhelming how much progress that we've made. Thank you.
Thank you, Irene. That is amazing that now is a chronic condition. It's not something, a death sentence. It's not a disease, an acute disease. And something for us to keep in mind. We offer also the Cancer Thriving and Surviving 6-week evidence-based workshop for people that are going through cancer treatment, but also that have survived. So I love how the connections are between one and the other happen. So thank you so much also for Donnelly for joining us. There's just a couple of questions. There's the chat is a bit quiet today, but nevertheless, I wanted to start with one of the questions in terms of the low number of lung cancer. First of all, can vaping, does it have to be cigarette or vaping as well?
So that's a really good question. You know, we've obviously seen an increase in vaping over the years. You know, it's a hard question to answer because typically a regular cigarette has a lot of different things in it. It's not just nicotine. There's tar, there's different things that are added to it. So it's hard to compare that to vaping, which is a little bit more purified in terms of nicotine. So probably vaping is a little less of a cause of lung cancer than a regular cigarette would be. We don't have a lot of information yet in terms of vaping alone causing lung cancer. We don't really have those statistics yet to say to be comparable. But just to say, if you're inhaling something into your lung, it's going to affect your lung tissue and it's going to affect your airway. It's going to cause some irritation of that airway, some inflammation. And we know that in cancer in general, over time, excessive inflammation can cause changes to the cells lining the airway, and that could potentially lead to some type of cell mutation and eventually cancer. So it is certainly a concern. Unfortunately, we just don't have the data yet to say exactly how is that comparable in terms of exposure to regular cigarette smoke.
Something that you discussed that is very encouraging, regardless of that, is that there seems to be, for example, public campaigns have helped in the reduction of smokers. It seems a smoking cessation program, so hopefully that will be one of the things that will contribute to people probably even vaping less. One can have a great effect on the
get away from people inhaling anything, you know, into their lung. Ideal. The other thing I wanted to mention that I forgot to is that we are combining our energies together in terms of screening with our Pink and Pearl event, which is actually occurring tomorrow afternoon, right, Donalyn?
You'll be there? Okay, Donalyn.
So that will be in the Rufschlager building tomorrow afternoon. I think it starts about 1 o'clock, 1 to 4. So this is actually an event that combines advocating for breast cancer screening with mammogram with also lung cancer screening. So we're going to have the lungs are going to be there, the boob is going to be there that people can look at. And we'll have a lot of information about the importance of doing screening in both areas.
Awareness. Yeah, that's why it's so important, the work that you're both doing. I apologize for our callers. Feel free to unmute. It's *6 if you would like to answer, I'm sorry, or to ask a question to, if you have a question for Irene or Donalyn.
Okay, my question is for the breast cancer. Is there age that women stop getting mammograms?
I'm so glad you asked me that. It wasn't in my presentation, but no, there's not an age that you stop getting your mammogram. As a matter of fact, the older we get, the more our chances increases of getting breast cancer. So we have a saying around Equal Hope that if you think you're going to live for 10 years, another 10 years that you should continue getting your mammogram. So if you're 75, you think you're going to live 85, keep getting your mammograms. We have had women diagnosed, I know at least 3 diagnosed in their mid to late 80s with breast cancer. The oldest lady I had diagnosed with breast cancer was 88 years old. And so there is not a time that we stop getting our mammograms. And I will reiterate, getting our mammograms every year increases our survivorship. It minimizes the invasive treatment. So it's very important that we, again, take a body inventory every day, body audit. Make sure everything still looks the same. If you see a lump, get it checked out. If you feel something strange, get it checked out. And ladies, by all means, continue to get your mammograms every year. Just one added thing, I know that the recommended age for mammograms is 40, but women under 40 do get breast cancer as well. So we want to make sure that you pay especially a special attention to your breast, to those symptoms that we talked about earlier, because you can be diagnosed with breast cancer under the age of 40. So you want to make sure, because you can get a screening mammogram, that you're doing your due diligence and doing your clinical breast examination and also doing your self-breast, being self-breast aware.
The reason I asked that question because I've been told that I have aged out of getting mammograms because I'm 88 years old.
That's interesting. That's
Yeah,
interesting.
yeah, that is very interesting. And here's the problem that I'm going to have with that is that I'm not a doctor. I'm not. I can only tell you from experience what I know from being in the community. A screening mammogram annually will not hurt you. It'll help you more than hurt you. And if I'm honest, I've heard that before, but I'm not a doctor. And so I can't really argue against what doctors say. I can only present to you the information that I know to be true, and that you should continue to get your mammograms, because you're 88 now. What if something happened next year? And it could. You never know.
Is there any place I can get a free one?
Oh, absolutely. I'm the queen of free mammogram.
Okay.
And so what I'll do is I'll put my number in the chat, and you can get in touch with me offline.
I'm on the
Oh,
I'm on the
she's
phone.
only audio, but let me give you the number if you have something to
I'm
write
actually going to
with.
give.
It's
I actually want
312.
to give you my cell phone number, which is 630.
660
No, 630
630
888
Mm-hmm.
1291, and you can reach me directly.
Okay. All right. Thank you. 630
Absolutely.
888 1291. Okay.
Yes, ma'am.
Thank you.
That'll get right to me. Absolutely.
Okay.
That's very
Thank
generous,
you.
Donalyn. Thank you so much.
Can
Yes,
I ask another question of the person that presented the lung
sure, go ahead.
presentation?
Go ahead.
People that I know they keep saying our environment is bad. Is there any way that you have research where people live near these expressways that are inhaling all of those fumes? Could they also be a cause of lung cancer?
Certainly the American Lung Association looks at those things. And I think just like Donalyn showed a map of, kind of different areas of the city, we do have those same statistics. It's hard to get the kind of the air quality samples to line up with the incidence of lung cancer in those different areas. But just because we do know that car exhaust is something that is a factor contributing to air pollution, there is a concern. I can't tell you for sure that we know that those areas have higher incidence rates, but we do know that certainly, cities that are more congested have higher rates than the rural areas. So, we're able to say that. I can't say specifically living near an expressway is going to be worse than living, just on a regular city street. But we just know that the particular matter in the air is a concern, and there's other things obviously in the air we breathe other than car exhaust. But we definitely want to continue to support, the laws that help, to preserve our air and keep these particular matters, at the minimum.
Thank you.
Thank you. Thank you for your call and for joining us today. So we are right at time. We greatly appreciate you both being here. Please, for everyone, feel free to share this lecture to your friends or other family members. Another caller has another question. I hear some sound in the background. Oh, no. Okay. Well, I just wanted to make sure. But thank you, Irene. Thank you, Darren Lee.
Thank you.
Thank you so much for joining us. And again, as I was saying, feel free to share the recording of this lecture, which is going to remain in our YouTube channel, so that more people can benefit from this important information. Okay, so let me tell you about what's coming up for us. What's next? Thank you. So we are going to be offering Take Charge of Your Health, which, as you know, is a free 6-week workshop for people with ongoing health conditions, in which you get to learn how to build skills to gain confidence, better manage your health, and therefore lead a more active life. Over the course of those 6 weeks, we discuss goal setting, nutrition, physical activity, medication, pain management, effective communication, and strategies for working with healthcare professionals. The next workshop that we're going to be offering is in person here on our main campus at Rush. It's going to be on Tuesdays, starting on November 4th through December 16th, and from 9:30 a.m. to noon. Feel free to give us a call, 1-800-757-0202. If you would like more information about this, or if you're ready to sign up, that's the same number for us. Then we're starting to volunteer, to recruit for one of our most popular volunteering programs. It's the Community Health Mentor Program. We are seeking new mentors for the 2026 year, and this unique opportunity connects adults with chronic health conditions to interprofessionals, to their teams from different disciplines. So if you have a chronic health condition, one or more chronic health condition or impairment, consider participating in this program. It's going to run once a month in the months of January, February, and March. And it offers also to the mentors telehealth training and a gift card stipend, so that as a thank you for your participation. So please join us to help shape the next generation of patient-centered healthcare providers while working toward your own wellness goals. So you can scan that QR code on the screen, or you can simply call us our toll-free number, which is 1-800-757-0202. And as always, we want to learn from you. So if you would like to let your loved ones or your physicians what matters to you, please consider recording a video. You can scan the QR code to record on a mobile device or a smartphone. Well, thank you, everyone. And our next lecture is going to be medication and aging in 2 weeks, Wednesday, October 29. So we hope to see you there. It's going to start, as always, at 1 p.m. So please join us and let others know about this. Remember that Rush Generations is here for you, not only for these health promotion and disease prevention programs, but also if you are searching for information about social care, or if you need to speak to a social worker, that's the same number to call, 1-800-757-0202. Thank you, everyone.